Maheen. We are from VRK Women's Medical College, and we will be presenting to you an interesting case of Marfan syndrome, which we have encountered in our clinical postings. An 18-year-old patient named MJ, resident of Hashmatpet and shopkeeper by occupation, came to the medical OP with the complaints of pain on the left side of the chest since 3 months and fever with chills. Chest pain was dragging in nature, strong in intensity, radiating to the left shoulder, upper neck, lower left jaw, and infrascapular area. Okay, yeah. The fever was mild and grade, insidious in onset, with no sweating, no diurnal variation, no aggravating and relieving factors, breathlessness from waking up from the sleep, and shortness of breath on brisk walking and climbing. There was no history of hemoptysis, cough, or hospitalization for any lung infection. Patient had 2 syncopal attacks within a year following extreme chest pain. There's no history of diabetes, hypertension, TB, and jaundice. Personal history: mixed diet, normal appetite, sleep, bowel, and bladder habits are normal. There's no addiction history. Family history: no one in the family has similar complaints and deformities. The patient was on analgesics for chest pain. On examination, the patient was conscious, coherent, and cooperative. Febrile, 103 degrees Fahrenheit. Respiratory, 32 breaths per minute. Blood pressure, 130 per 80 mmHg. Pulse is irregular, 60 beats per minute. The height of the patient was 190 centimeters. Weight was 45 kgs. The arm span is 198 centimeters. Upper segment of the body was 90 centimeters and lower segment was 100. The patient has mild scoliosis of the vertebral column. Scallos, dolichocephalus, high arched palate, and crowding of upper teeth was present. The pigeon-shaped chest deformity, pectus carinatum, was present on chest. Ligament laxity, joint hypermobility. The patient has long limbs and extremities, arachnodactyly. Pes planus is seen in feet, striae on the shoulders. The wrist sign and thumb sign are positive. The lower segment of the body is more than the upper segment, and the arm span is more than the height. On palpation, the apex beat is felt in the left fifth intercostal space. On auscultation, mitral click and pansystolic murmur are heard. Ophthalmic examination, the patient has the lens was spirophakic and fundus was normal. Lower quarter of the lens was seen in both the eyes, suggesting of ectopia lentis. CNS manifestation, there's no neurological deficit. The patient was qualifying, actually the Gren criteria is 4 skeletal abnormalities: ectopia lentis, dilatation of the ascending aorta or mitral valve lesions, dural ectasia, and any one member of the family who meets the same criteria. The pathogenesis regarding the syndrome is defect in the fibrillin 1 gene on chromosome 15, which is a glycoprotein which codes for elastic fibers. So a defect in these fibrillin gene leads to defective microfibrils formation and excessive transforming growth factor beta signaling, which leads to defective microfibrils which are excessive in blood vessels, ocular and skeletal system, and ligaments. So a defect in these lead to Marfan syndrome. So provisional diagnosis based upon clinical examination investigations, we reach to a diagnosis of Marfan syndrome. Management is by investigation, slit lamp examination for ocular defects, X-ray of hands, chest, and metacarpal index more than 8.4, CT, MRI, ECG, echo, and gene analysis. Treatment: propranolol, which lowers the BP and further prevents and delays the aortic and mitral surgical correction of aorta. Mitral valve repair. Then scoliosis: if it is mild, then mechanical bracing and physical therapy. If it is more, then surgery is indicated. For dislocated lens, it does not need surgery as such. Gene therapy, that is angiotensin 2 receptors for transforming growth factor beta signaling reduction, is under clinical trial. So the conclusion is based upon the investigations and mostly on clinical examination, we give the diagnosis as Marfan syndrome. And the take-home message is: Marfan's is mitral valve prolapse or mitral regurgitation. A is for aortic regurgitation and aortic valve lesions. R is retinal detachment and other ocular defects like subluxation, dislocation, cataracts, and microcornea. F is fibrillin gene defect. A is for arachnodactyly, and N is for no neurological deficit or 9 feet height, indicating the tall personality and long limbs. And S is for skeletal deformities like scoliosis and pigeon chest, pectus carinatum, ligament laxity, and joint hypermobility. So 2 words about Marfan syndrome. It's named after Anthony Jean Marfan. He's a French pediatrician. It is an autosomal dominant disorder, but 1/4 of the patients express as new mutations, which are sporadic. And Marfan syndrome is a congenital anomaly characterized by disorders of the connective tissue, mainly manifesting as skeletal, ocular, and cardiovascular. Incidence is 1 in 5,000 to 10,000. individuals. Thank you.
In Marfan syndrome, in cardiovascular system examination, what you will get?
In Marfan syndrome, on auscultation, if there is a murmur like mitral valve prolapse, if there's a regurgitation, we get a pansystolic murmur. If there is aortic dilatation and all, we have the murmurs. In auscultation, we can find out the murmurs defectively.
So how will differentiate rheumatic MR with Marfan's MR?
Marfan's, we have the other features of Marfan's, no ma'am. So, okay.
Clinically, cardiovascular system. How will differentiate?
It is in Marfan's, it is heard only at the apex. In
rheumatic all over chest? What do you mean?
It will radiate to the axilla back.
So more musical, okay? In Marfan syndrome, prolapse, no? So mitral valve prolapse leading to more musical murmur rather than in other cases you will get pansystolic murmur, okay? So that is the difference, not the site.
Is it associated with AR also, aortic regurgitation? Is there?
No,
Aortic regurgitation.
no, sir.
Usually
No, sir.
Marfan's is associated with aortic regurgitation also.
No, it was not
There are-
associated.
No,
No?
sir, AR was not
It
there,
was not
sir.
associated.
Yes, no, no.
5 mm.
4 to 6 square centimeter. Mitral stenosis grades are there, ma'am. Less than 2.
Severe.
2 is severe.
Any ophthalmic manifestations?
Yes, sir. Microcornea, strabismus, ectopia lentis, cataract, retinal detachment.
Retinal tears also and lattice degeneration also is seen.
Which type of, what could be the complaint of a patient with Marfan syndrome in ophthalmology?
Mostly he was myopic, sir. No such complaints as such. There's high grade of myopia because elongation of the globe is there.
Which direction possibly the lens may move? Which direction the lens, ectopic lens? That subluxated lens, which direction it moves?
It is outward and above, temporal side. Lower border was seen. Thank you.
Any questions from the audience side? Wow. Now I see raising hands. Yes. Introduce yourself first, your college, and then your question.
This is Pranali from Kamineni. I have just a doubt in your case. I want to know whether you told in your history that after waking up the patient is having breathlessness.
Yeah.
I wanted to know whether because of breathlessness patient is waking up or he's having breathlessness after waking
No,
up. And can you elaborate on that?
No,
Having paroxysmal nocturnal dyspnea. Was having paroxysmal nocturnal dyspnea. So after 2 to 3 hours of sleep, he gets up, feels breathless, like that. He was
can-
not breathless before.
Can you tell the pathology behind that paroxysmal nocturnal dyspnea?
During sleep, what happens is edema of fluid enters into the vascular compartment. Then when it enters into the vascular compartment, venous return to the heart increases. Already the heart is diseased. Ventricle is diseased ventricle. So it cannot compensate for the increased workload during sleep. It leads to increased pulmonary venous pressure. This leads to pulmonary congestion after 2 to 5 hours of sleep. This causes breathlessness and patient gets up.
Myself, Mansa from Kamineni. You said that the most common subluxation of lens is outwards and upwards. Why it is only that presentation? Why not others?
It is typical of Marfan syndrome, outward displacement of lens, whereas inferior displacement and inward is seen in homocystinuria. This is differential of Marfan's and homocystinuria.
Anyone else?
I am Naresh from OMC. What is the life expectancy of the patient?
Life expectancy is reduced to 1/3 compared to normal individual, and it directly reflects aortic dilatation. The more the aorta is dilated, the more the life expectancy is reduced.
Do heterozygous individuals also manifest the symptoms?
Yes?
Do heterozygous individuals also manifest the same symptoms?
Yes. Autosomal dominant trait. This is autosomal dominant trait, and our patient was sporadic. Parents were not having the defect in gene.
Anyone else from the audience? Okay. Yeah. Thank you. Thank you so much.